So I'm not going to say very much. I'm going to try and set up a little bit of a framework so that I want to invite all of you to begin to talk about the agenda that Steve was referring to. This is a figure that we developed for the work that we're doing internationally with other research funders, looking at what are the levers for improvement to reduce waste and improve value in the research ecosystem. And as many of you are aware, there has been a movement internationally to look at avoidable waste in research investment and a variety of factors, including starting with the end user in mind, asking important research, not conducting research we're already at a point where we're beyond equipoise, all the way through to making sure that all research is available and data can be also accessed so that we can do replication and reproducibility and combining. So that work, which was launched in a Lancet series in 2014, has led to one aspect of the ecosystem, the research funders, starting to work together to try and move the levers that we can. But I know that in the room we have a number of other people that are going to be important. So what I've done is I've taken this idea of heterogeneity of treatment effect and all of the things that we've talked about today. We're putting it in the circle, saying that we all should be focused on research that actually meets end user needs. So it gets back to a little bit of what our patients told us, that we need to start with the end in mind. We need to know what's going to help patients and those that are making decisions. We need to do it with the involvement of patients and the public, so they're in the whole, they're in the substrate of the ecosystem. But each of these actors, the funders, which we represent, the researchers, many of you are researchers, the research institutions, the journals, regulators, are also actors. Now, some of you say, well, where am I? The guideline developers, the clinicians, the systems, the payers. Well, you're really in the end users. You're using the research, and a lot of what we've heard about today are some of the challenges that will come down the pike. But I wanted to put this up because I'm going to say very briefly, what we as a funder are doing. This is a meeting that indicates the commitment that PCORI has made in this area, and I'll talk briefly about a few of the other things we're going to be doing. But then it would be very helpful to hear from the rest of you, from your perspective, are there some sensible next steps that you can see that we might take to move this agenda forward? Because really, it is an awesome agenda, but there's a lot of hope that we can together collaborate to bring more effective evidence so that we do have personalized evidence-based medicine. So what I will say is this. This meeting, tomorrow we will have a technical expert panel that David and others have assembled. We're working on trying to assemble some of the basic methods, particularly around outcome risk prediction, which was the original part that David talked about. We've gone into benefit prediction and other areas, but it seems that of all of these areas of uncertainty, we can all understand that if you can accurately predict outcome risk, then even if you don't have treatment effect modification, you're going to have more benefit in the higher risk people. Now, interpreting that is something else, but that is a place where we feel like we can confidently start. There's still lots of questions about that. If you think about, from a funder perspective, what we're going to ask people to analyze, what we're going to ask people to report, and then, as Steve said, how confident can we be in those findings? If you get it from one trial, do you need to replicate it in a second trial, as we saw in the STRIDE trial and then the Accord BB trial? Is that enough? If you're developing a model within the trial, do you need to? Is that enough, or can you do it a within trial model through split sample, through bootstrapping, through something else, or do you really need to have it applied elsewhere, and or do you need to go to another randomized controlled trial? As Steve was saying, we don't know any of the answers to these questions, but we want to start working them through, because the evidence, while it's not going to be sufficient, we right now don't have any of this evidence. And we need to start looking at where we can responsibly provide the evidence, proof the evidence so it's true, so then we can help, as a research funder, help produce the evidence needed for tools and action to bring more applicable evidence to patients. So I know that there are a number of people in the room. For example, Avot, Close enough? Close enough? Avot. More enthusiasm. Avot. Yeah. So, but Avot, I think you may have some comments to make about Steve's comment about, do we have a number? Do we have a cadre of established, validated prognostic models that really could come off the shelf for some of these situations? I think there may be more than we're aware of, and I would really like to hear you talk about that. Some of the others, journal editors, regulators, others, what are some of the levers that you see that or the caveats that you would give us as a funder as we try to responsibly move towards producing more evidence in this sphere? And any other comments that you'd want to make. I especially want to invite those folks who have listened, very carefully listened and paid attention and not had a chance to say one dang word. So I'll stop right now so you can have a chance to say a word. And Christine, please start.